Exogen ultrasound bone healing system is a unique device that accelerates all stages of the fracture healing process. Using low-intensity pulsed ultrasound, Exogen activates a biological healing response at the molecular level. Level 1 clinical studies showed that Exogen accelerated the healing of fresh fractures by 38% and was proven to heal 86% of non-unions in just 20 minutes a day. To achieve this active healing response, Exogen low-intensity pulsed ultrasound waves pass through skin and soft tissue to reach the fracture. As the Exogen signal reaches the cells, surface molecules called integrins begin to cluster, triggering an organization of the cytoskeleton. This activates multiple signaling pathways that work to drive new blood vessel formation, stem cell differentiation into chondrocytes and osteoblasts, and mineralization, all of which are necessary for bone repair. Let's look at how Exogen works at the molecular level. Exogen increases expression of COX-2 at the fracture site. COX-2 produces PGE2, which drives multiple steps in the fracture repair process. Exogen ultrasound also increases the level of growth factors, such as VEGF, that promote new blood vessel formation. These factors induce repair cell activity and recruit new cells for the healing process. By increasing the levels of bone morphogenetic proteins and other specific growth factors, the Exogen signal stimulates the formation of chondrocytes and osteoblasts and helps accelerate the formation of bone. By enhancing expression of multiple factors at the molecular level, Exogen accelerates the healing of fresh fractures and resolves non-unions, helping patients return to their normal activities more quickly.
Good evening. My name is Tim Williams. We're very delighted to welcome you to tonight's lecture of distinction from the British Orthopaedic Foot and Ankle Society. Tonight I'm proud that it's been sponsored by the previous advertiser, Exogen, and I'm very grateful to their support. Tonight's talk is on hindfoot injuries involving the calcaneum and the talus and dislocations, etc. And I'm proud to welcome Chris Blundell and Mark Davies from Sheffield, who are going to be providing the talk for us tonight. Chris is an ex-president of the British Foot and Ankle Society, and Mark Davies is currently the secretary. And more broadly, they host one of the best fellowships in the UK that I'm certainly aware of. A few housekeeping points. Please do ask questions using the icon Q&A at the bottom of the Zoom screen. And we will be posting, if it's not there already, the code for the feedback so that you can get your certificates afterwards following the lecture. So without further ado, welcome Chris and Mark, and thank you very much indeed for delivering tonight's lecture.
So thank you very much, Tim, for that excellent welcome. I'm Mark Davies. I'm one of the consultants at Sheffield Teaching Hospitals, and together with my good friend and colleague Chris Blundell, we're going to be talking to you about hindfoot injuries over the next hour. Evening, Chris.
I'm Chris Blundell. Yeah, good evening. Hello, Mark. Hello, everybody else. Okay, Mark, it's over to you first.
So why ask us in Sheffield to give this lecture? Well, Sheffield is a reasonable sized city in the UK and has its fair share of urban trauma, road traffic trauma, etc. But it has a history of heavy industry, and that brings in some fairly decent trauma of its own. But if you couple that with the fact that we're right next door to the Peak District, which is the busiest national park in the UK, we have an awful lot of leisure activities, and that brings in the trauma too. So I think we're in a reasonable position to be able to talk about tonight's subject. So what we're going to talk about is the key anatomy that you need to know. And also we're going to cover the patterns of injury for talus, calcaneal fractures and other hindfoot dislocations, and coupling that with the surgical approaches you'll need to treat them. At the end of that, there'll be some Q&A and then a couple of case discussions. What we won't be covering is any pediatric trauma, that's beyond our remit. And although it's our favourite, we won't be talking about navicular or cuboid fractures. So what is the ideal hindfoot injury? Well, We'd have no trouble with soft tissue cover. The surgical approaches would be dead easy. Vascular supply would be plentiful. It'd be dead easy to get in and reduce and restore anatomy because there would be so few joints to consider. Fixation would be easy to apply. Post-operatively, rehabilitation would be fantastic, good results, would be few long-term complications, and the outcomes from the patients would be fantastic. But that's not what we're dealing with, and we all know that. So let's start with a little bit of the key anatomy that you're going to need to know. Firstly, it's like a lot of bits in orthopedics, ring structures come in, so the forearm and the pelvis, etc. But there is a ring in the hindfoot, and that may not have been appreciated before. And it consists of the body of the talus, the neck, the head of the talus, the navicular, the bifurcate ligament, the anterior process of the calcaneus, and the posterior facet. Most of those you'll be familiar with, but the bifurcate ligament, next slide, is a thick condensation of the capsule that goes from the anterior process of the calcaneus onto the navicular and onto the cuboid. And it's a pretty tough structure. Next slide. The anatomy of the talus is interesting. It's frustral in its shape. It's a truncated cone or a lampshade in its shape. 60% of it is covered in articular cartilage because it has 6 articulating surfaces. But unfortunately, it has no muscle or tendon attachments, and that's part of the reason why it can be rendered avascular so readily. The blood supply to the talus has been very well documented historically, and this paper is well quoted and is familiar to you all. But it's basically 30 wax specimens from the 1970s, and the arterial supply was worked out from this paper. But actually, although that tells you about the geography of the blood supply, it doesn't actually quantify it. And the next slide shows a key paper which I think is really very relevant and is worthwhile knowing, because this MRA study basically quantified the contributions of the arterial supply to the hindfoot, and you can see that there. Next slide. The bony anatomy of the calcaneus. Well, again, it has 4 articulating surfaces, 3 that articulate with the talus, and then 1 that articulates with the cuboid. And you can see also a very large attachment area for the Achilles tendon. Medially, the hard bone of the sustentaculum tali is a key structure when you're thinking about the pathoanatomy of the calcaneus. Next slide. So the only real angiosome that you need to know in orthopedics is this one. And you can see the wax dye has been injected into the posterior peroneal artery, and the classic appearance there of the angiosome mapped out, where the blue is colouring the angiosome of the skin, right down to the glabrous dorsal skin junction, and right almost just across the midline on the back of the heel. Next slide. This is crucial because trying to respect that angiosome when raising a flap is the crux of the extended lateral approach. And you can see that's marked out there on the skin, and the angiogram is very telling. Next slide. So let's start with fractures of the talus. Next slide. They can be very complex, and that's partly because of the anatomy of the bone itself, but also the pathoanatomy is often very difficult to deal with. Thankfully, they're not particularly common, and particularly the serious ones, the body fractures, are not that common. But the trouble is that they don't do very well, particularly if they're not managed very well, and therefore they are life-changing events. So what kills the talus? Well, firstly, it's the injury. There's nothing you can do about that, but nonetheless, you need to bear that in mind. The second thing is something that we can all do something about, and that's the surgery. And that's the skill and part and parcel of this lecture. So death of the talus is likely to occur if you extrude it, but even then you can find that there is at least a 10% chance of survival. Body fractures have a 50% chance of AVN, and neck fractures less so. All of the more peripheral fractures, though, don't have an effect in compromising the blood supply of the bone. So the outcome is dependent upon the fracture pattern, but also the degree of subluxation. In other words, the amount of energy that has gone through the neighbouring joints. If there's an open injury, and those are common, they're about 25% of talus fractures, then that also ups the ante. But the subsequent surgical insult is important, and therefore you need to try and minimise that. Next slide. With body fractures, again, the fracture pattern is absolute, because on the right-hand side there, you can see a sagittal split in the talus that actually has a relatively benign outcome in terms of avascularity. The coronal split, though, is much more of an issue. Again, open injuries have a deleterious effect, and the subsequent surgical insult is important to minimise. So, as demonstrated in the last slide, plain films are absolutely mandatory, but you'll find that you'll get such terrible views in the ED that they're not often very useful. And CT is the workhorse for all hindfoot injuries, but particular for planning your talus management. Over to Chris.
Thanks, Mark. So if we're talking about fracture of the talus, one of the ways of considering it really is to think about the energy imparted. And so broadly speaking, you can consider them as either a low or moderate energy injuries or high energy injuries. We're going to concentrate really on high energy injuries because they're much more significant in terms of creating a poor outcome. And certainly in a major trauma centre, these are the fractures that exercise us more. They're actually more frequent, certainly more frequently witnessed, and are more important. So high energy injuries can result in fractures of the body or the neck or the head, or more uncommonly posterior process fractures. But what's absolutely essential is the soft tissue injury associated with a high energy injury. The literature is not very helpful, if I'm honest. It's mostly level 4 evidence with small numbers of cases. At least part of that is because of the heterogeneous nature of these fractures. The classification systems we have probably don't allow us to really consider all of the facets of the injury sustained that are related to the outcome. The soft tissue injury is where the energy obviously is most evident at the initial presentation of the patient, and certainly about a quarter of neck and body fractures are associated with a soft tissue injury. And in this case, you can see here, this is a skin burst as a sort of a peri-talus dislocation. When we've got this big soft tissue problem, we need to really consider early and fairly aggressive management. We need to look at those soft tissues, whether they are open or whether the skin is just threatened, as you can see in that image on the left, where it's just about to come through the skin. The dislocations have got to be reduced expediently, and we use the scan, span and plan kind of modality, like you'll all be aware of for the management of tibial shaft fractures. The reality is a lot of these injuries actually have already gone through the emergency department having a scan. So actually they end up having a scan and a span and a scan and then a plan. And actually for Mark and myself, who are quite interested in being very detailed about the outcome of these injuries, we will get post-operative scans. So they've actually got a scan at multiple intervals there, really looking at how well this has been reduced, particularly if it's been reduced elsewhere or you've not been involved, or if there's a hardware issue or later talus collapse. So thinking about fractures of the body of the talus, these fractures almost always have a fracture line that involves the joints, usually extending into the lateral process of the talus and usually involving either the ankle and or the subtalar joint. And we can consider the planes of these fractures as these images nicely demonstrate. So the coronal plane at the bottom there is your red line, and that's pretty much ever present. The sagittal plane really can only be appreciated if there's significant displacement or you've got a CT. The axial plane is really described but very rarely witnessed even on the CT scans. The body fractures of the talus are actually more common than neck fractures. So although you'll all have studied or be studying or about to study Hawkins classification because it's a sort of exam type favorite, the reality is that body fractures actually are more common than neck fractures. But talking of Hawkins classification, here it is because it has to be here. This fracture line extends into the sinus. Hawkins classified originally 3, and the 4th one was added by Canale. The incidence you can see on the left, with 2s and 3s being the most common. The way to think about this is a type 1 is just the fracture line present. And then if you add the numbers of joints dislocated, it gives you either a 2, a 3, or a 4. So a subtalar joint dislocation isolation gives you a 1 because of the fracture, and then another 1 because of the dislocation. And that leads you then to a 3 and a 4. 4s are relatively uncommon, but they're very, very significant and severe if you see them. Head of the talus fractures are less common still, almost always associated with a subtalar joint dislocation in our experience. Fractures of the posterior process a weird sort of group of fractures, really, not very well defined, almost always associated with bits and bats of fractures around the talus, and really associated with the most difficult of body fractures, if present, because of the comminution that they represent. So then moving on to the low and moderate energy injuries, these are a different beast, really. So these are usually associated with avulsions around the talus. As Mark said, the talus has got all these capsular attachments, but no tendon attachments onto the talus. So these fractures, by way of being avulsions, are by definition peripheral. For example, an inversion injury will give you a little supination line that you can see. Posterior process fractures, again, are avulsions at the back of the capsule where the talus is rigidly adherent with capsule to the calcaneus. Lateral fractures are very relevant. They're probably amongst the more common of these low energy injuries, but they're associated with not a very good outcome, really, and spotting them is very important, and considering fixing them or at least immobilizing them. They're associated with the dorsiflexion eversion pattern of injury where they nutcracker the lateral process off. So the other low energy injuries around the talus, of course, are the osteochondral fractures. We won't really dwell on those because they're really a whole lecture series in their own right, but suffice it to say that acute osteochondral fractures are avulsion fractures or impaction fractures around the margins of the talus. Mark.
So as promised, we're going to talk about the approaches for talus fractures. You can come at it from all angles: anteromedially, anterolaterally, posterolaterally, and posteromedially, and we'll cover all of those. Equally, you can use osteotomies to gain better access, but also it's important to remember that the fracture lines themselves can be good access points. So this is the workhorse approach, the anteromedial approach. It's the midpoint between tib ant and tib post, and you can see that it's the watershed between the two arteries on the right-hand diagram. It's a particularly good historical approach for talar neck fractures, and the reason for that is that usually the talar neck fractures and the talus actually adopts a varus position, usually because of the position of the foot on impact. So there often is medial comminution and some form of medial dislocation of the body of the talus, and this approach will allow you to gain a reduction. It is extensile, and therefore it does allow you also to deal with any talar head fractures, and therefore it is the approach of choice for those. Anterolateral approaches, well, we're spoiled for choices here. The classic one is the blue line, which goes in line with the third metatarsal. I have to say it's not my favoured one. The red line is one that is in line with the fourth metatarsal and effectively is the skin incision you would make for a triple fusion or a subtalar fusion. So that in itself tells you that it gives you good access to the subtalar joint and the calcaneocuboid joint. And the great thing about it is readily extensile. So that little curve going behind the end of the distal fibula will allow you access posterolaterally to the talus. And of course, it then preempts any further subtalar fusion. The green line is a more modern approach. It's been described by Lyndon Mason et al., and it's the lateral transligamentous approach. And the next slide shows that this really does give you great access to the talar dome. And the only place that's very difficult to access through this approach is the posteromedial segment. Next slide. So the AO technique classically has told you to do a two-approach technique, anteromedially and anterolaterally. And that does give you really good access to the subtalar joint. It allows you to excise fragments and gain your fixation, grafting, etc. But my worry about that is that you're making incisions and you're potentially aggravating the zone of injury. So I think you should proceed with caution with your dissection. And I would encourage you to be thinking about that vascular supply to the talus and thinking about different ways of combining these surgical approaches. If you are going to use the two approaches, you do have to be mindful of retaining a big skin bridge. Next slide. The posterolateral approach is particularly useful because it's excellent at approaching the subtalar joint and therefore is great at reducing dislocations in Hawkins 2 type fractures. Equally, it allows you that access point where the 2 grey stars are to gain your fixation along the axis of the talus, and that gives you really good compression and a nice solid strong fixation along the talus. Next. The posteromedial approach, this is a little bit of a niche one. The patient obviously has to be prone. It's important to stay lateral to the FHL tendon, but this is often used in combination for those tricky posterior process fractures that are associated with a whole host of other local fracture patterns, as you can see here in the X-rays. Next slide. So I mentioned about the use of osteotomies, and these can be fashioned through the anteromedial approach and employing a medial malleolar osteotomy. It's really important with this that you protect the tendon of tibialis posterior. It's so easy for that to be damaged in the saw cut. I would recommend that you pre-drill your fixation screw holes, and I always use a chevron cut in order to relocate the osteotomy as accurately as possible. And you can be quite generous and do quite a plafondplasty in order to get really good access to the body of the talus. And you can see that there. Next slide is the lateral malleolar osteotomy. I'm sure Chris will agree. I've only ever done this literally 2 or 3 times in the last 15 years. So it's not commonly needed, but it is basically part of the extensile approach of the blued-lined lateral approach I showed you earlier. You do have to take a lot more care with this osteotomy because it's very difficult to move the fibula safely out of the way to get decent access. And in my opinion, it gives you limited access. And this is, I think, where the Lyndon Mason approach actually has some merit. Next slide. So the use of fracture lines I mentioned, the dissection has already been done. So you're not going to cause any more trauma than that original injury that we talked about earlier. So you use that zone of injury and you preserved uninjured vascularity. So this is a sagittal split in the talus that you can see here on the left-hand side. The medial malleolus has been reflected to give really good access to the talar dome. And then that has been fixed with polyglycolic acid pins and then anti-glide plating of the medial malleolus. So use of fracture lines, look at the CT scans because that might gain you a good access point. Next slide. So what are the complications of fixing talus fractures? Well, there are lots of them. Malunion is definitely underappreciated, and I think it most commonly occurs as a malreduction on the table. And that's because it's difficult to reconstruct the shape of the talus. And if you can't reconstruct the shape of the talus, you will end up with incongruent joints. And there are so many joints around the talus that can become incongruent. Sometimes that malunion occurs because of later collapse of the talus, because the talus dies back. And it can be a big generator of post-traumatic arthrosis. The key thing about malreduction on the table is to try and recognize it early. And of course, that's such an easy thing to say. But if in doubt, as Chris said, the post-op CT can be very valuable. So in the bottom left, you can see that there's a talar body fracture, and you can see that it doesn't look right on the lateral. That's the CT prior to fixation, and you can see that there is not congruity of the 2 surfaces. But this has been fixed relatively percutaneously. Someone's tried to be very cute with this, but actually hasn't achieved a reduction if you look really carefully on the fluoroscopy film. And the immediate post-operative film, again, there's something not quite right about it. So next slide. So if in doubt, do a post-op CT, and you can see here that the malreduction is very obvious. And then get it right first time, but get it right second time as well by going in and doing an appropriate approach and reducing the talus. Next slide. More often than not, though, the malreduction happens as a late down the line appreciation. Quite often the talus is badly reduced. It's often reduced into varus and malunites in that position and creates a cava varus deformity. And really the only salvage for that is a triple fusion, as you can see illustrated below. What other complications? Well, infection, because as I said earlier, a lot of these injuries are open, therefore they are contaminated at source. And there may be a delay in them presenting to you because the patient hasn't been found, or other injuries have taken precedent, but that's one of the key factors in determining a poor outcome. Next slide. Everyone worries about AVN, and the images below are a lady who had normal ankle for the first 11 years after her talar body fracture, and then on year 12 she presented with those images there. So it can be very late in its presentation. But I think that we're getting more vigilant and better at appreciating this, and we're better at treating it, so that actually our rates of AVN are slowly coming down. And you can see that that key paper in 2015 shows that those percentages are improving because our management is improving. Next slide. So osteoarthrosis is clearly going to be a problem here. The ankle, the subtalar joint, and you can see that's nicely illustrated by a patient of mine who I fixed 12, 13 years ago. Left side was a Hawkins 2 talar neck fracture, and the right side was a Hawkins 3. He's not done badly insofar as he's still got both of his feet, I guess you can say. But look at the florid arthrosis in ankle, subtalar and talar navicular joints. Next slide. Non-union, I think, really occurs in body fractures. There's often a little bit of partial AVN and collapse, and it certainly could happen with malreduction, and that actually goes on and creates a lot of arthrosis, I'm sure. Next slide. Over to you, Chris.
Thank you. So let's move away from the talus then and move down the body to fractures of the calcaneus. So the first question you may ask is, well, why the hell are we even talking about these? Because, you know, nobody treats these anymore. We've all read the papers. We all know that these injuries should be left alone. Well, when we think about them in the round, they're not rare. 1 to 2% of all fractures and 60% of all tarsal fractures. So for foot and ankle injuries, these are relatively common. They're often intra-articular. 1 in 3 of them is associated with another injury, and we all remember that those are spinal fractures of the lumbar spine, particularly, and pelvic injuries, because these most often occur as a fall from height. They occur typically in young working males, and that creates a high impact in terms of physical work and the duration of time before they get back to work. So they can be manifest with pain and loss of function, loss of earnings, and a need subsequently for further surgery by way of fusions. So we've got a bad injury, it's intra-articular, and it does badly if it's left alone. Well, by any other fracture standards, that would mean we just need to fix it. You wouldn't normally leave an intra-articular displaced fracture alone. Well, surely we should just do that. Well, no, maybe we shouldn't, because, you know, things can go wrong. And when they go wrong in this area, they can be very seriously wrong and irrecoverable. So the stakes are high if we leave them alone, and the stakes are high if we try to intervene. So how do we know what to do? We can injure nerves as well, leaving them with not just numbness, but a painful numbness. Sural nerve damage can result in lateral-sided foot pain and an inability to wear shoes, which in the Western world is a disaster. So whether we're going to fix them or not, surely really what we really need to turn to is the literature. Well, historically, lots of little studies with short follow-up, and these characters can often be the reprobates of the world and society, and difficult to find and difficult to follow up. So let's look at some PRCTs that have come about in the last 20 or so years to see if that can help drive our thinking. 3 seminal papers that really those of you who are approaching the exam should, I think, have read and certainly be aware of. And I'll just briefly go through these in turn, but this is no excuse for not actually picking up those articles and reading them, guys and girls. So Buckley's paper from Canada, which is now 18 years old, essentially was a valiant attempt at a multi-centered study in Canada. And in essence, what they showed was that men over the age of 50 involved in heavy work and receiving a medical legal involvement did better if treated non-operatively, whilst women, younger men, those with a more severe injury. So remember, the Bowler's angle, a low Bowler's angle, means that the subtalar joint is flattened, and that's associated with a bad outcome. So they do better with surgery, as do those which are comminuted, those not involved in medical legal work and in doing lighter work. And in summary, they found that the better you fix them, the better the results. No great surprise there. High energy injuries do worse, no great surprise there. But look at that bottom line. Those that are managed conservatively have got a greater than 5.5 times increased likelihood of requiring a further major surgical intervention, which will also take them out of work in the future for a while. Per Zangren from the Karolinska Institute in Sweden did another fantastic paper looking at very long-term outcomes in his own group of patients, finding that there was a trend in the long term. Remember, Buckley's paper was not very long-term review. So in the longer term, there's a trend towards a better outcome in the operated group, both in terms of physical return to function as well as pain. But again, demonstrated clearly a 2.5 times reduced prevalence of subtalar arthritis in those that had had anatomical or near anatomical reduction. And then the paper that you probably all heard of was the UK heel fracture trial, which was another valiant attempt really of a study. A lot of patients screened, not a lot of patients actually involved in the final study. And it was widely disseminated in the British Medical Journal with the sort of strapline that there was no benefit with surgery. So that got people's attention, and that's the one that has led people perhaps to, in my opinion, wrongly assume that none of these patients should ever be operated on. And there was some criticism that's been published around that article as well. So the evidence is a little bit mixed, but there's a trend towards non-operative for those that are in the middle, but we're not entirely sure. Remember, these studies looked at the extended lateral approach, which we know is associated with soft tissue trouble, and if not done well, can result in a bad outcome. So maybe in the current world, we should be thinking of percutaneous or more minimally interventional ways of fixing these fractures, because the anatomy needs to be restored, but the risk is to the soft tissues. We still really are waiting for a good PRCT comparing percutaneous with open or percutaneous with non-operative management. So let's think about the fractures themselves. We'll start with extra-articular fractures. These are the minority group, and these really are anterior process tuberosity and sustentacular fractures. So fractures of the anterior process can either be avulsion in a manner of the foot being pulled into adduction so that the calcaneocupoid joint is pulled apart, or it can be compressed in a nutcracker type of mode. Often you'd see that, for example, with a Lisfranc injury. Tend to be avulsions, tend to be low energy. Because they're relatively subtle, they can be missed as well, and if missed, are important. So you'd have to look for the tenderness to palpation really in this subtle group of injuries, which is usually just anterior and anterior distal to the tip of the fibula. There's medical legal papers written about these missed injuries. So you do need to spot them and probably treat them with cast immobilization. And if it's late, contemplate the idea of excising them. Really, the graft and fix is only for the heroes with a very big fracture. Compression fractures, when the foot is into abduction, are often seen on CT only. There's often associated injuries elsewhere, but you've got to contemplate restoring that foot shape to try and avoid a late planar valgus foot shape if left alone. Tuberosity fractures, these are a small group, often in fact are a tongue type group of fractures associated with an intra-articular fracture. So in isolation, a tuberosity fracture not very commonly seen. However, those avulsion fractures that you see of the posterior aspect of the calcaneus are really important because they're associated with soft tissue damage and the risk to the skin at the back of the heel. And these are one of the rare group of foot and ankle injuries that needs to be treated not just soon, but urgently. If you ignore them, then the skin can break down and you're left with a hole which is open to a fracture simply because you didn't treat them well early. Sometimes these fractures are neuropathic in their presentation, so they can present late because the patient's not aware of what they've done. And you'd see that characteristically in diabetics, but also in alcoholics and those with a neuropathy. And in that case, if they present late, the skin is at threat. Sometimes you just need to excise them with or without part of the Achilles insertion or all of the Achilles insertion. If they present in a timely way, then we would advocate an extended lateral approach to get them down and get them back. And we tend to fix them with a plate, or you can do it with a tension band application. Percutaneously, they can be fixed, but just beware that you may be going through that damaged skin. And so you need to be very cautious doing that. You need to use big screws and engage the plantar cortex. Otherwise, you're just firing those screws into the breeze. Post-operatively, it's an equinus cast to take the tension away from those soft tissues, and those soft tissues take a long time to heal, and you've got to look at them really carefully whilst they're in the plaster. So don't just stick them in a plaster and ignore them for 6 weeks. Have a look in the interval. Sustentaculum tali fractures often associated, in fact, in my opinion, really usually associated with some sort of dislocation or subluxation of the subtalar joint. You're looking at a swollen, painful foot, and these are often spotted really only on the CT. Because of that ring that Mark was talking about, the sustentacular fractures are often important in terms of preserving stability of the subtalar joint, and often we would fix those using a medial approach, taking the tib post tendon down to gain access to those fractures and fixing them in a relatively simple way. Intra-articular fractures of the calcaneus are the lion's share of these and make up the more important area, and Mark's going to tell us about some of those.
So we've been trying to talk about reasons why you should fix calcaneal fractures, and this is definitely one indication. You can see here where there's an associated subluxation of the ankle, then that is clearly an indication to go in and fix. Next slide. Similarly, calcaneal fractures can be associated with a dislocation of the subtalar joint, and again, that's another good reason to go in and fix. And you can see in this instance that, again, the sustentaculum tali has been targeted for the reduction. So one of the other absolute indications for surgery is if you're suspicious of subfibular and peroneal tendon impingement. And clearly from this cut on the CT scan, the fibula and the calcaneal wall are abutting each other. That's never going to be a good outcome for the patient. You have to intervene. Open fractures, well, now these are slightly controversial. As we know, when we've seen calcaneal fractures, they have plantar wounds almost invariably. The low energy fractures actually have a reasonable outcome. So your elderly person with an open calcaneal fracture, you can treat fairly aggressively and fix them. It's the high energy ones where debridement, external fixation and minimal percutaneous methods should be used rather than trying to do definitive internal fixation, because that does have a high chance of failure. So fractures of the calcaneus, 90% of them occur from a fall from height. We know that the target population are 30 to 60-year-old males. The talus is basically acting as a blooming great hammer and smacking the subtalar joint. And the sustentaculum tali is the constant fragment. And we've alluded to this classification so far. Sanders is probably the most commonly used. Sanders 1 really is a mandate to treat your fracture non-operatively. It's the Sanders 2 and 3 that have been the controversial ones that have been included in the studies that Chris has already talked about. Next slide. Sanders 4, in other words, where there is complete disruption with multiple fracture lines going through the posterior facet, has actually now got some supportive literature to suggest that actually reconstructing these early on and then doing a primary fusion gives a much better outcome than coming back and doing a delayed fusion. Next slide. So the Sanders 2s, the aim, as always, is to restore the posterior facet and to try and rid the patient of fibular impingement and to try and improve the hindfoot biomechanics, getting rid of the hindfoot varus and valgus and improving the calcaneal pitch. You need to essentially remove the anterior calcaneum from underneath the talus so that the subtalar joint can work and function again afterwards. Next slide. How do you do that? Well, you need adequate surgical visualization. That could be an extended lateral, it could be through a sinus tarsi approach, it could be arthroscopically assisted. It doesn't really matter, but it's something you need to train to be able to do and restore all of those key criteria to the calcaneus. Next slide. So how do we do that? Well, traditionally that has been the extended lateral approach, and we talked about the angiosome earlier. It's important to wait for the blistering to disappear and the skin to start to wrinkle. So we have to respect that perineal angiosome and create a decent limb between the two limbs, a good angle of more than 90 degrees. Next slide. If you don't do that and you do an old-fashioned Seattle type hockey stick incision, then there is a temptation to do that. What you'll find is that there is a chance that you'll end up with wound edge necrosis. Next slide. So alternate approaches for the calcaneal fracture are sinus tarsi approach or percutaneous approaches or dry arthroscopic assistance. And none of this was covered at all in any of the papers that we've heard about before. And the aims of that is really to try and minimize the soft tissue trauma to that angiosome. Next slide. So this is two examples here of a sinus tarsi approach, one with a more percutaneous application of screws, another with a plate applied underneath the posterior facet. Next slide. So what are the complications of calcaneal fractures? Well, malunion is a big thing. The heel can remain very short, very wide and high riding, and that's a very difficult deformity to correct. Next slide. This is probably the most paralyzing problem, is the fact that you end up with a dorsiflexion malunion of the talus in the mortise, and therefore ankle motion is disrupted because of the calcaneal fracture. Again, a very difficult thing to restore function for. Next slide. We've already touched upon this perineal impingement. Next slide. And wound breakdown. Next slide. Deep infection is often sequelae of poorly managed wound breakdown. You can see here a sequence of a case of mine from years ago where I fixed the calcaneus. There was a problem with the wound. The metalwork that was subsequently removed. The wound still didn't settle down, and you can see the moth-eaten appearance of the calcaneus, and then having debrided the area, filling that area with bone cement and antibiotics. Next slide. Over to you, Chris.
So we're on the run up here now. So these last series of slides really are not for the faint-hearted. We're talking here about a hindfoot dislocation cohort. So subtalar joint dislocations really should be considered as really a simultaneous dislocation of the subtalar joint and another, usually the talonavicular. When you think about the anatomy here, it's really very difficult to imagine how you could dislocate the subtalar joint whilst leaving all of the other joints intact. So really it should be considered as a series of dislocations, most often of the subtalar and the talonavicular and or calcaneal joint, cuboid joint, and lastly with the ankle as well. The description is the position of the subtalar joint relative to the calcaneus, i.e. the calcaneus relative to the talus. So it's probably the end point of a extrusion of the talus, and the subluxation of the ankle joint occurs really in extreme subtalar dislocation. So that's the worst of the bunch, really. Medial is the largest group, so think this is the calcaneus lying medial to the talus, and usually occurs in a plantar flex foot that's then inverted. And usually these are reducible, but sometimes they are not because of interposition of the tib post or the FDL tendon around the talus. So here you go. Here is one. You can see those images. The subtalar joint's clearly dislocated, but look at the talonavicular joint. You could drive a bus through that. So the talonavicular joint's gone too. And these are the images you saw before of that very threatened skin. And you can see the foot medialized relative to the tibia and the talus. So reduce them, CT then to check the stability, and often you'll see these ring of avulsions all the way around, and depending on where they are, depends really on how you immobilize or mobilize, and you need to consider that really in the individual situation. Laterally, this is much less common, but occurs in the opposite modality, so in dorsiflex foot with forced eversion. And that would be most often seen probably in motorcyclists where they put the foot out, speedway riders, that kind of thing. CT's really, rather than useful, I think is pretty essential here, to be honest, to ascertain exactly what's going on, because the anatomy is complex. And in this case, you can see a sustentaculum fracture again reduced to provide that ring of stability whilst the foot has fallen off the sustentaculum. Anterior and posterior are rare. Anterior, obviously, the foot is pulled forward off the talus with a planted lower leg, and posteriorly is the opposite modality of that. These are rare. Here is one. If it's stable, you can treat that in a cast. And really you need a CT to again look at all of those marginal fractures and just consider, is there something here you need to stabilize to provide that ring of stability back. It's usually the sustentaculum tali actually, which we tend to find is the pivotal point to be fixed. As you could see on that CT in the middle there, you could see that would be important. Extrusion of the talus, well, this is obviously the far end of that spectrum of hindfoot dislocations, usually very violent and usually associated with a lateral wound, as you can see here. Closed extrusion happens, it's not common, but you can see what's happened here when the inferior syndesmosis has been pulled apart to allow that extrusion. You can see over time we've got a Hawkins type sign which resolves in time with a talus that's maintained its blood supply. The outcomes are difficult to ascertain because it's really case reports, but certainly at least half of these go on to AVN. In fact, arthrosis seems to be uncommon for some reason, but infection, if open, is obviously a grave concern. So when you're looking at hindfoot injuries, really, there's no ideal one. The list on the left would indicate things which are going to go well, and on the right, things that are not going to go well. If you're struggling with your soft tissues, struggling to reduce them, struggling with your access, those are the cases where you can expect complications and stiffness and unpredictable outcomes. And don't take these on if you don't know what you're doing, would be my advice. Phone someone who can help you or get some assistance if these are rare and difficult injuries. So thank you very much, and we'll hand back to Mr. Williams, I think, now for any questions that have come through.
Thanks, guys. That was brilliant. Thank you very much indeed for taking the time to put such a thorough lecture together. I'm very grateful indeed. There have been a few questions come through, if you don't mind. Mark, about the approaches for talus fractures, have you kind of developed a favorite, or do you use a more fracture-specific approach to how you're going to, which incision you're going to use?
Yeah, I think you have to be very a la carte. The great thing about these talus fractures is that they're all unique, and you have all of these different approaches in your armamentarium, and you should consider how you're going to use those to best effect to treat your fractures. So there isn't a recipe book, but if you know all of the ingredients, you can basically put together a plan to get yourself out of any of the holes, because you might need to be able to use an osteotomy, but you might use a fracture line, and the only way to do that would be through a medial approach, etc. But by and large, I think that posterolateral fixation for most tailor neck fractures is far superior than trying to do cross screws from the front.
Mm-hmm. And I guess also remember, you don't need to fix them through your approach. So you may approach them through a utility medial approach, but you may see and visualize the fracture that way, but actually fix it from the back, which I think is probably the most common way that we would do that. So you open it up medially, but actually at least one of your screws goes through the back posterolaterally to anteromedially. That's
certainly what I do. And the fracture specific thought is the way forward. I agree entirely. And sticking with taluses, a good question here is about the closed talus fracture or talus extrusion. Does it have to be done in the middle of the night? Is this an emergency procedure that requires reduction, or can it wait till the morning and better with a foot and ankle surgery and do something about it there and then?
Well, I think, yeah, Mark's nodding his head, and I think the three of us would all agree that you're better off waiting for the cold light of day to know what you've got. What you shouldn't really do is further traumatize the soft tissues by a slightly haphazard attempt at reducing them in the emergency department, for example. There's loads of spasticity around, particularly tib post and the Achilles, that will make reduction in the ER really, really hard. So what you don't want to do is take that patient to theatre, give them a GA, and then struggle again because you're not quite sure how to get them back. And then in the morning, you're presented with all of that shenanigans through the night. So I think if you know what to do, if it were me and someone presented it to me at 10 or 11 at night, I probably would take that to theatre. But if it were one of my shoulder colleagues, I would hope that they wouldn't, and they would give us a fresh approach in the morning.
Yeah, I think it's more important for you to get all the information together. So I would get a CT, have the patient ready for first thing on the trauma list in the morning. That way you've got fresh staff, you've got all of the kit, you've got staff that knows where all the kit is. You don't get that in the middle of the night. So you don't want to do anything that's going to compromise your management because the patient will suffer.
And the things that stop the reduction, those FHL and TIB posts that can get wrapped around the neck. I once had one, well, it's not that long ago actually, where they'd reduced the talus and debrided the wound and put an X-fix on. It wasn't until I went back the following day, because it wasn't quite right, that in fact TIB post and TIB amp were flipped the wrong sides of the talus. So the functional recovery of that would be a disaster. So, a valiant effort, but it didn't really help.
And in the more severe fractures of the talus, and probably go to the calcaneus with this as well, do you ever go straight to fusion as a primary procedure?
Definitely with the Sanders 4 calcanei. I really think you could spend ages trying to piece that posterior facet back together. It's the most difficult jigsaw puzzle in the world. You'll never get a great outcome, but you will get quite a good outcome if you go hell for leather and get a fusion straight away. I think with the talus, actually less so, because what you don't end up with is an awful lot of comminution on the undersurface of the talus. It's usually reconstructible. And of course, the other side of the fracture line will be in the ankle. So where do you stop your fusion mass? I think it's probably better to reconstruct the talus and then come back.
And with your worrying, sorry, Chris, carry on.
No, I was just going to say that I think the only thing I would say about the primary arthrodesis of the subtalar joint for a calc fracture is it's still pretty bloody difficult. You've still got to rebuild your calc. You've still got to get the length and breadth correct. The only bit that you don't have to worry about so much is reconstituting the posterior facet, but every other aspect of it is still rebuilding the calc like you would anyway. So it's not a kind of slam bam, thank you ma'am kind of easy solution. It's harder to do that than it is to walk away. But I'm sure Mark's absolutely right.
And possibly the unknown question I struggle with at times is, after you fix the talus fracture, how long do you keep them non-weight bearing in a cast? What's your kind of a post-op regime? When I first started, I kept a patient up to a year non-weight bearing, or rather off sport, should I say? Certainly got them walking a bit earlier, in order of this worry, this collapse, etc. What's your thoughts on it?
Well,
Mark.
I think the key thing here is to get the wounds to heal. The moment you got your wounds to heal, then I put them into a cast that they can remove, and I get them doing exercises straight away. Mm-hmm. And so by week 6, you then have some mobility, and I always get them walking at 6 weeks, because although Hawkins sign is fantastic, we haven't even had a chance to talk about Hawkins sign. Although Hawkins sign is very reassuring, it doesn't happen very, very often. And you've got to get them up. You're going to have to do something to rehabilitate them. So you may as well just bite the bullet. So my view is just get them going at 6 weeks.
What is Hawkins sign, Mark, in brief?
So that's the sign where you see subchondral osteopenia, usually on the AP view of the body of the talus. And it basically indicates that there must be some vascularity in the talus, because there's resorption of bone and in the subchondral area.
I remember Professor Jimmy Richardson from Oswestry, who's no more. He had this thesis, which I thought was genius, but never had the balls to put it into action, which was that maybe you should get the patients walking early and stop them walking between weeks 6 and 12, when the talus is at its most fragile from a vascular point of view, and then let them walk again. But I mean, my patients wouldn't, I don't think most of my patients would get it. I'm not sure I get it, but I'm entirely with Mark. It's about wound healing first, then it's about motion, and lastly, it's about weight bearing, in that order.
And that segues quite nicely to the kind of non-operative management of calcaneal fractures. So when you've decided to do that, do you keep those immobilized in the cast, or there used to be a tendency for getting them moving straight away and walking on them early? I don't do that personally. I tend to keep them in the cast. But what are your thoughts on it?
Well, I think you've got to treat the whole patient, haven't you? That's the sort of PC world that we work in, and it's true. You know, those calc fractures are often in people who aren't the smartest or the most compliant, and you've got to protect them against themselves. And it's that group that we would tend to keep in a cast. But, you know, if heaven forbid I fell out the window of the room I'm in at the moment, bust my calc, I would hope that someone would let me start moving it pretty early, because I would keep non-weight bearing. So I think motion is really important to restore function, but you've also got to protect the soft tissues against the sort of, you know, the desire they may have to nip back on a roof and jump off again, or steal some lead, or whatever it is that did it in the first place.
A couple more questions coming in from the guys. Somebody's talking here about having to wait 3 weeks before fixing a calcaneum. Do you worry how long you have to wait, and is there a limit before where you would say it's too late?
3 weeks is fine.
Yeah.
It's harder, but it's certainly very doable. It just means that everything's a little bit more stuck down. But with patience, you'll mobilize the fragments and get it back together. I haven't fixed a talus at 3 weeks. I think that would be really difficult.
I think the one thing I would say about the calc is that actually the soft tissues are lovely at 3 weeks, but you have to take the fracture apart again. And when you get into it, the chondral surface is often a bit milky looking and pretty unhealthy because it's been sitting inside the bone. So I think those patients end up with quite a nice soft tissue healing, but very, very stiff if you leave them, you know, beyond kind of 3 weeks. I've done one at 7 weeks, and I got a very nice result anatomically, and the x-rays look great. Patient couldn't move the subtalar joint. So, you know, I think the earlier you get involved, once the soft tissues allow you to, the better your motion will be. And that's the trade-off, isn't it? Always of making sure the soft tissues settle whilst at the same time getting the patient moving it. Because the other thing you said is the non-operative management post-op. Well, the operative management post-op, once you fix them, again, it's about the soft tissues first. And once they've healed, get them moving. You know.
Any views, a question here coming through from an anonymous attendee, any views on calcaneal nails? Mark?
I've never used them apart from on cadavers. And I think that they have some merit. There's no two ways about it. If you're familiar with using them, then they do a good job. But I personally have never used one in anger.
Chris?
I've only used them in the dead. Got an excellent result, I'd have to say. I think it's not so much about what hardware you fix these fractures with. It's about respecting the soft tissues and getting the anatomy right. And if a nail somehow manages to get the anatomy right and protect the soft tissues, I'm all for it. And that's why we did try them in cadavers. The fact that we've never done them in the living, I think, says it all really about our marks of my experience. You know, they were great in the dead, but I wouldn't want to use one in the living personally. But
and a final question, probably regarding the dislocation part of it. In an open talus extrusion, do you try and retain the talus or discard it?
No, put it back.
Keep it.
Perfect. I think on that, that's a lovely one. You mentioned, guys, you kindly brought a couple of cases.
Yes.
We've got a bit of time. If you wouldn't mind going through a couple of cases, that'd be fantastic.
An ultrasound bone healing system is a unique device that accelerates all stages of the fracture healing process. Using low-intensity pulsed ultrasound, Exogen activates a biological healing response at the molecular level. Level 1 clinical studies showed that Exogen accelerated the healing of fresh fractures by 38% and was proven to heal 86% of non-unions in just 20 minutes a day. To achieve this active healing response, Exogen low-intensity pulsed ultrasound waves pass through skin and soft tissue to reach the fracture. As the Exogen signal reaches the cells, surface molecules called integrins begin to cluster, triggering an organization of the cytoskeleton. This activates multiple signaling pathways that work to drive new blood vessel formation, stem cell differentiation into chondrocytes and osteoblasts, and mineralization, all of which are necessary for bone repair. Let's look at how Exogen works at the molecular level. Exogen increases expression of COX-2 at the fracture site. COX-2 produces PGE2, which drives multiple steps in the fracture repair process. Exogen ultrasound also increases the level of growth factors, such as VEGF, that promote new blood vessel formation. These factors induce repair cell activity and recruit new cells for the healing process. By increasing the levels of bone morphogenetic proteins and other specific growth factors, the Exogen signal stimulates the formation of chondrocytes and osteoblasts and helps accelerate the formation of bone. By enhancing expression of multiple factors at the molecular level, Exogen accelerates the healing of fresh fractures and resolves non-unions, helping patients return to their normal activities more quickly.